Welcome to this presentation on the recognition and management of chronic hypoxia and pre-existing fetal compromise. So we're going to look at a fetus who is going to have a problem in the antenatal period. So if this is the normal placenta, which is essential to transfer not only oxygen and then to remove carbon dioxide, just like our lungs, but placenta does much more than that. It also transfers nutrients. It removes waste products like the kidney. And that's the reason why if you have a placental failure as a human fetus, it is much worse than just having a lung disease. So if you have placental infarction thrombosis, or if your placentation was abnormal in early pregnancy, leading to poor development of chorionic villi, placental villi, you are in trouble. As adults, we need our lungs. When we run, when we jog, we need good lungs to take in oxygen to keep the myocardium in positive aerobic balance all the time. Just imagine, you're going to run a marathon or you're going to sprint with one lung or both lungs really messed up with disease. It's very certain that we will collapse if you undertake a hypoxic exercise. The reason we produced this checklist called Fetal Monitoring Checklist, initially we intended it for chronic hypoxia, but again you can see it's applicable for any pre-existing injury. And it is in a systematic manner to test and to make sure that the myocardium is in positive aerobic balance at the beginning of labor. The brain, autonomic and somatic nervous systems are well oxygenated and with no depression. And to find out about the placental function by the presence of shallow or late decelerations, the ones that recover slowly back to the baseline. And when we did our physiological CTG master classes, we knew that none of us would be concerned about this baby because these reflex responses of the myocardium, as you can say, they quickly drop to the baseline, from the baseline. And when the contraction goes away, they quickly come back to the normal baseline. And therefore, a midwife who does intelligent auscultation, who listens immediately after the contraction, he, she, or they would not pick these decelerations. And they should not be picking these decelerations because they are not due to hypoxia or acidosis. And we said that the uglier the decelerations, the better, because they are ugly decelerations tell you they are transient interruption in oxygenation, hypoxemia, not hypoxia and acidosis. And the fetus is able to recover immediately and continue the journey of labor, showing a stable baseline and a reassuring variability, showing that central organs are well oxygenated. And that's why when we do physiological interpretation of CTG, we only see the morphology of the decelerations to understand the mechanism of ongoing stress, but we don't count them, we don't name and shame them. We look in between the decelerations to determine fetal response to stress. Now, if you look at the different types of hypoxia, what we are going to concentrate is the long-standing or chronic hypoxia. So imagine if you are a fetus in utero, you need optimum oxygenation. So what do you have to do? You need to have sufficient oxygen coming from your mother to the placental bed. And then you need to be able to transfer that oxygen and also the metabolic waste products, including carbon dioxide, to and from the umbilical blood vessels. And after you pass it on to the umbilical cord, you should have an intact and patent umbilical cord so that all these goody oxygen and nutrients can come to you and all your metabolic waste products can go back again. And you should have a normal metabolic demand. If you are infected, if you have chorioamnionitis, your metabolic demand increases. And this balance gets upset. If you're a large fetus of a diabetic mom, macrosomia, your metabolic demand increases. And the placenta may not be able to keep giving you oxygen to meet your demands in late labor, because your demands are high and the contractions are cutting the oxygen. And if you have a normal oxygen carrying capacity, i.e. normal amount of hemoglobin, so you should not have chronic fetal anemia, you should not have fetal-maternal hemorrhage, because then you lose your hemoglobin that transfers oxygen. And you should have a normal function of the myocardium without arrhythmias and problems, structural problems in the heart. If this is the situation, and this is what most of us want to be as fetuses, your central organs and the peripheral organs, they're well oxygenated. You're not going to be in any trouble. Now imagine if you are in trouble. In other words, if you're in a situation where your oxygenation is no longer sufficient to meet your metabolic demands, you need to protect three organs. The brain, that is for intelligence and vital functions. Your heart, which is a muscle pump that perfuses oxygenation to all the organs, including the brain, and your adrenal glands, because you need it. You have to release catecholamines to increase your heart rate, to get more oxygen from the placenta, increase your cardiac output, pump faster to your central organs. And when in trouble, you also cause peripheral vasoconstriction to centralize blood from the periphery to the center. And not only that, you would break down your glycogen to glucose to give more energy substrate. So the fetal catecholamine response, it increases the baseline heart rate. It causes intense peripheral vasoconstriction to divert the blood from non-essential organs to the central organs, what we call priority organs. And this centralization keeps the central priority organs, heart and the brain and the adrenal gland, from going into anaerobic metabolism and developing lactic acidosis and damage thereafter. That's because you are stealing the oxygen from your feet, your hands, your liver, your kidney, all the other organs, and then supplying it to the central organs to give as much as oxygen as possible. And as I said, in life, you need oxygen, you need food too. And this placenta is no longer able to transfer glucose because it is small, it is diseased. And you need to be able to generate glucose, especially for those organs and cells which only depend on glucose. So you as a fetus, I as a fetus, when we are exposed to uteroplacental insufficiency, we would be able to do these processes to be well. And in the antenatal period, if the placenta fails, we know as fetuses that there'll be reduced availability of oxygen to supply the metabolic needs of the priority organs. And therefore, we need to make some intrauterine adaptation to protect these central organs. So let's go and look what happens if there's a uteroplacental insufficiency. As a fetus, I'm very clever. If my placenta fails much earlier in gestation, in a way I'm lucky because I have time. I have time to do my compensatory responses, including reduction in the fetal growth. Whereas when I'm having a late onset placental failure, that's the time I'm in danger because I don't have enough time to make those compensatory responses. So I can make my organs smaller and then divert those blood supply from those smaller organs to my vital organs, my central organs. I can shut down my kidney blood flow. Obviously, you will pick me up by measurements because I'm going to be small and I'm going to have oligohydramnios. I'm easily picked up. And if I am referred to a good fetal medicine unit, they will do doctors and they will deliver me at the right time without me sustaining damage. But when my placenta fails in late pregnancy, 36, 37 weeks, I am in trouble. You know why? I haven't made my organs any smaller. So my kidney and the liver and the spleen and the gut, they are all asking for the same amount of oxygen as the brain, heart, and the adrenals. They haven't given up. And I don't have time. And when I go to my midwife or my obstetrician, when they measure me with a tape, because I've been growing well, I'm not going to be small. So they miss me. Late onset placental failure is the one that gets missed. And I will then come to you with evidence of RUPI on the CTG trace. We'll be looking at it later. Relative uteroplacental insufficiency. So let's take a step back and work out if in a case of chronic uteroplacental insufficiency, which is going on for 5, 6, 7 weeks, is early onset, what does the fetus do? So I will be releasing catecholamines as a fetus. I'll increase the baseline fetal heart rate. So you will see that on the cardiotocograph. I will redistribute. So if you do scans, you will find that I have a head sparing effect, smaller body, bigger head. And also, when you do Dopplers, you will find that I'll have more blood flow to the middle cerebral artery. And when you measure my abdominal circumference, you will find that it is very small, AC diameter. You know why that is? Because I have no glycogen. I'm breaking down my glycogen. And I store glycogen in the liver. So that's why when you measure the abdominal circumference, it will be very, very small. But the good news is, if someone recognizes me at this stage and delivers me at the right time, I'm going to be absolutely fine. But if someone misses me at that stage, see what's going to happen to me. I'm going to have a continued catecholamine surge to perfuse the placenta and get more blood from the placenta and perfuse my vital organs. And therefore, my baseline heart rate will be higher than expected for the gestational age. Because I am failing in my compensation, so despite redistribution, despite increase in the heart rate, and all the compensation I have done is going to fail. And when I go into decompensation of the brain, when you have CNS depression due to acidosis, I will have reduced or absent baseline variability. And because the problem is in the placenta, where there's going to be accumulation of chemicals, even with Braxton Hicks contractions, because the placental pools are diseased, they are small, you're going to have an onset of shallow or late decelerations, the ones that slowly recover back to baseline, not the big ugly ones. So I'm going to come to you with these three features: higher than expected baseline, reduced baseline variability, and the onset of shallow or late deceleration. And you, being a good midwife or a good obstetrician, because you understand science and the pathogenesis, you would make a diagnosis of chronic hypoxia. So let's look at this situation. A primary gravida is coming to you. She's low risk. She's about 41 weeks of gestation. She's just saying, guess what? My baby is not moving well, as I was experiencing before. So if you're going to assess fetal well-being in this case, we are going to look at the myocardial function. We are going to look at the brain, and we are going to look at the placenta. These are the three aspects the baby is interested in. So if you're looking at the myocardium, from our physiological CTG master classes, we know that fetus should have a stable baseline. It should not be fluctuating. It should be stable if your myocardium is in good oxygenated state. And the baseline heart rate has to be appropriate for the gestational age of this baby at 41 weeks. If you're looking at the brain, we need to be looking at normal variability. And as labor continues, every 50 minutes or so, I'm going to go into a deep sleep cycle as a human fetus. And therefore, you're going to see evidence of alternative epochs of normal and reduced baseline variability, which we call cycling. And if the placenta is functioning well, then you should not be having any deceleration that slowly recovers to the baseline. So with that in mind, let's go and look at this baby, because we have to individualize care. We cannot use one guideline with 110 to 160 baseline heart rate in all babies. They don't do it in adult medicine, because if a baby doesn't have enough reserves, like a chronic uteroplacental insufficiency, and that baby is not going to increase the heart rate from 110 to 160 to become abnormal by your guideline. In the same way, if all of us go to the gym and do the same hypoxic exercise, not all of us will be able to increase the heart rate to 150 and sustain it. An athlete will do it. An Olympic athlete will do it easily. But someone like me, old and bald, I won't be able to do it. In the same way, not all fetuses will be able to increase the heart rate above 160 and to maintain it for 30 minutes or 40 minutes. So in this situation, she is admitted in low-risk labor. So if you do intermittent auscultation, or what we call intelligent auscultation, the midwife who simply follows guidelines as does intermittent auscultation will call this normal. But the midwife who does intelligent auscultation will know that 110 to 160 baseline is only for the population. And therefore, she will be asking, or he or they will be asking the question, is the baseline heart rate I'm seeing appropriate for the gestational age of this fetus? And that's only because we know that 110 to 160 is derived from a human population of babies, not for the baby in front of you. If you take a human population, obviously, if the baby is relatively preterm, 36, 37 weeks, you will have the baseline heart rate in the upper limit of normal. And that's because the vagal dominance, the parasympathetic influence, increases as the labor advances. As the pregnancy advances. So the baseline heart rate 160, as you go to 39, 40 weeks, it starts reducing because there's a strong vagal dominance. And therefore, at 40, 41 weeks, we cannot accept a baseline over 140 beats per minute. And this has been shown by scientific evidence when they looked at 11,000 babies in the antenatal period and then had a computerized analysis. You can see as the gestational age advanced, there's a progressive reduction in the baseline heart rate. And that's because of vagal maturation. There's a progressive maturation of the vagus nerve. And therefore, at 41 weeks or beyond 40 weeks, you can see the two standard deviations, if you look at it, is well below 140. And that is why when we do physiological CTG interpretation, the first question you ask yourself is this baseline heart rate I'm seeing appropriate for the gestational age of this fetus? And that's what we'll be asking. So here, this woman is coming to at 41 weeks with reduced fetal movements. What would you expect? If the heart is in good oxygenated state, it's going to pump well. It's going to have a stable baseline. If the brain is getting good amount of oxygen through the carotid arteries with a good cardiac output, you're going to have a normal variability and cycling. And if the placenta is functioning well without any uteroplacental insufficiency, you're not going to have any late or shallow decelerations. In other words, you're not going to have any chemicals that needs to be washed off after the contraction. So you should not be having any slow recovery to the baseline. So if you look at the baseline at 41 weeks, it should not be above 140. So this is the kind of CTG that you will be looking for. But guess what? This is what they found. So you know, based on your knowledge of physiology, this is chronic hypoxia because the baseline is higher than expected at 41 weeks, which is associated with, you can see reduced baseline variability and shallow decelerations. So once you make the diagnosis, you would have saved this baby because you know science. If Edwin Chandraharan, the obstetrician who managed this case, did not know science, but he is following a blind guideline, for him, it is suspicious. That's what has sadly happened to this baby. He called it suspicious. But you wouldn't make that mistake because you know it's higher than expected baseline. That means the heart is pumping faster. because of catecholamine response, and you have got reduced variability and absence of cycling. That means the brain is depressed due to acidosis, and you have got shallow deceleration. That means those placental villi are messed up, and the baby is not having enough pools of blood in the placenta. So even Braxton Hicks contraction can cause these shallow decelerations. So you have made a diagnosis, but Edwin, the obstetrician, hasn't, because he is using a guideline that says normal, suspicious, pathological. But you would make a diagnosis of chronic hypoxia in this case. Once you make a diagnosis as a doctor or midwife, then the treatment is easy. Chronic hypoxia, there are two options: whether we continue labor or do an emergency cesarean section at that time. If the woman has come to you at full dilatation from home, she's a multip, and you see this, you're weighing the risk of an emergency cesarean section for the mother and the baby at full dilatation versus a quick vacuum of forceps to deliver the baby in the next 10-15 minutes. But if the woman is coming to you at in the antenatal period or in early labor, take a step back. If you have coronary artery disease, would you want a gym trainer to push you in the gym until you collapse and die? No, because we know that if you have acidosis in the brain and your placenta has failed, the baby will not be able to tolerate these contractions. It's basic, it's not rocket science, it's very basics in medicine. Because you will have further decompensation with contraction. Because what do contractions do? They squeeze the umbilical cord and they cut off the placental blood supply. And these contractions are not static. As the labor advances, they are going to be more progressively stronger, longer lasting, and more frequent. So if the baby is already having depression of the brain due to acidosis, and there's evidence of pre-existing compromise, you wouldn't want, if it is your baby, to be pushed in labor with contractions. So you would, once we realize it is our baby, if you put yourself in the shoes of your baby, you wouldn't call it suspicious and wait. You would say, I know what's going to happen to this baby. Let me examine. If she is nowhere near full dilatation where birth is imminent, I would recommend a cesarean section without further stress. Because these contractions, you can see, when you're in a situation like this with poor placentation and already decompensated with acidosis, every contraction matters because it causes cord compression. And most of these babies, though we don't see it, they have oligohydramnios. That's part of the disease process because they shut down their kidneys. Though we don't see it, they have it. So with the contraction, cord is also not going to get squeezed. So after you divert blood from rest of the body to the central organs, what do you do next? You have to make the same kind of compensation in the brain to protect all the vital centers in the brain stem. So if the contractions are allowed to continue, you have to make difficult decisions as a human fetus. You need to take blood from other areas in the brain, which are non-essential from a survival point of view, to supply your brain stem where the vital centers are: cardiac center, respiratory center, swallowing centers, etc. And what do you do then? You start losing blood in the frontal lobe. You lose your memory, your personality, all the higher functions, arts, crafts, painting, those kind of skills that babies bring from their grandparents and great-grandparents, they lose it. Then if you allow contractions to continue, you have to make sacrifices. You have to lose your Broca's and Wernicke's areas, which loses your language ability, speech and language. You lose your memory. And then finally, you lose your occipital lobe. You become cortically blind. And this is the reason why diagnosis of chronic hypoxia is hugely important. We may not be able to prevent the damage that has already happened, but we can prevent further damage and intrauterine demise of the fetus. But previous damage, none of us can prevent it. It has already happened. But additional damage can be prevented due to superimposed hypoxia. Otherwise, progressively, more and more centers in the brain will get damaged, and the baby might have severe neurological injury. So you can see the checklist was designed to detect the myocardium, to make sure that the autonomic nervous system and somatic nervous systems are fine. So those are the fetal central organs. Then we are going to look for placental insufficiency by excluding late and or shallow decelerations. And then the wider clinical picture. In this case, the woman came with reduced fetal movement. There is a very important piece of history. And with that, what we are trying to do is that beginning of labor, at the time of admission, is the myocardium is in positive aerobic balance? Is the brain in the positive energy balance, aerobic balance? And is the placenta functioning well? So we can ask this question at the beginning of labor. Is this fetus fit to undertake the journey of labor? A journey that is associated with progressive hypoxic stress. It's not static, it's progressive. And therefore, we need to make sure that this fetus, whether the fetus is able to do that. So if you apply this checklist in those hospitals who have implemented physiological interpretation of CTG, this is what they use, because they make a diagnosis now. When they ask the question, how is the fetus? They know it's higher than expected baseline, reduced variability, and shallow decelerations. They would have made a diagnosis of chronic hypoxia. And otherwise, you would expect at 41 weeks, the baseline to be lower with normal variability and cycling. So if they have used the tool that hospitals are using, this is based on the International Consensus Guidelines on Physiological Interpretation of CTG, which was produced by 34 CTG experts from 14 countries in 2018, they would have easily recognized this problem, because their checklist would have shown them that the baseline heart rate was not appropriate for gestational age. The baby did not have normal variability and cycling. There were no acceleration, and there were shallow decelerations. And therefore, chronic hypoxia would have been recognized. And even the history, you can see reduced fetal movements would have been recognized from history. And they would have avoided further stress and recommended birth. But in this case, sadly, they use national guidelines. You can see how guidelines are promoting harm, because by grouping these decelerations into various categories without any scientific evidence, how could you save human babies? And these are all arbitrary parameters. And here the baseline is 150. According to that, it is reassuring. Really? This baby is 41 weeks. It's not reassuring. And they are looking for typical big, ugly decelerations. The moment you understand physiology, you know that the big, ugly decelerations are the best ones to have. That shows good fetal response. And that shows cord compressions, which can be corrected. But uteroplacental insufficiency, they won't have big decelerations. They are shallow decelerations. And you can see why they missed it. If you see normal guideline, it's 110 to 160. And even if the variability is reduced, the guideline wants them to wait for 90 minutes, 40 minutes to be suspicious, and 90 minutes to be abnormal. Really? When you come to the labor ward with uteroplacental insufficiency and acidosis in the brain, if it is your baby, my baby, would we allow this to happen? 90 minutes of additional stress? Well, Edwin Chandraharan follows guidelines. So that's what sadly happened to this baby. And the baby is telling us, please, 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 I'm not suspicious, take me out. Whereas babies like this, who are being taken unnecessary for cesarean section because of pathological CTG, these babies are telling us, please, please, please leave me in. I'm just having a good time. Just like you in the gym, you're breathing deeper because you're doing hypoxic stress. Are you going to be in trouble? Do they come and intubate you in the gym trainers? So they know that you're breathing deeper, wider because of the exercise you're undertaking. And therefore, these babies who are exposed to exercise stress, your contractions transiently compressing the umbilical cord, they are showing a stress response. They are not suspicious. They are not pathological. Those of us who understand physiology, you would call this gradually evolving hypoxia, which is compensated. The brain is well oxygenated. This baby doesn't need any treatment. If at all, reduce the stress to bring the catecholamines back to normal. But this baby needs urgent treatment. But sadly, those who follow the guidelines take this baby to the operating theater. This baby is left suspicious. So then the rituals start. Can you believe obstetricians and midwives? We are treating hypoxia and acidosis with water, fluids to the wrong patient, mother. If my wife carries my child and goes to the pediatrician and my child has severe hypoxia, bronchial asthma or sepsis, imagine what would I think of that neonatal nurse or pediatric doctor if they are busy giving water to my wife because she's carrying the child. When the woman in pregnancy has 6 liters of fluid, she has got 50% extra plasma volume. Some of us, because we don't understand physiology, we call it suspicious and give water. And some of us keep changing the position, left, right. When there's chronic hypoxia and acidosis, do we really seriously think putting the woman on the left side will suddenly make the placenta bigger? It won't. It's a structural problem in the placenta. Your positional change is only for epidural-related hypotension or cord compression, not for placental problem. And then all these will cause delay, and that's what sadly happened in this case. So they called a senior consultant, senior came, and he or she looked at the CTG, looked at the guideline, and said, this is just suspicious. And this vaginal examination, they say, let's do an artificial rupture of membranes to look for meconium. And the baby was shouting, please, Edwin, don't do that. Because you understand from your physiology knowledge in medical school that if you do artificial rupture of membranes, I'm going to release, my mother is going to release prostaglandins. Those are going to increase the contractility. I'm already finding it difficult. Don't increase the contractility. And also, when you do artificial rupture of membranes, when the amniotic fluid runs out, I already have oligohydramnios. If you take the protective effect of the amniotic fluid, when I have little left, I'm going to have a sustained cord compression. I'm going to die in front of you. And don't tell my mother later on that is unexplained, we couldn't do anything. No, you are the one who is causing it. That's what the baby was telling me. But then Edwin Chandraharan follows guidelines. So they administered 1 liter of fluids because guidelines says give fluids for suspicious CTG to the wrong person, of course, so that the wrong person, the mom also can have dilutional hyponatremia, pulmonary edema, and cerebral edema. So they changed to left lateral and they said 90 minutes because according to the guidelines, 90 minutes is the time to call it pathological. But this baby is saying, no, you don't need 90 minutes. You know the answer in 10 minutes if you understand physiology. Because I've got a higher than expected baseline, reduced variability, and shallow decelerations. No one does CTG interpretation in isolation, looking at the variability, how long it is for, looking at the decelerations, how long are they for, what is the baseline, how it is for. No, you look at the whole picture, looking at the type of hypoxia. So as we said, when you do artificial rupture of membranes, it really makes it worse for babies who already have pre-existing hypoxia. But here, that was done. And immediately you can see the change. See how the uterine contractility has increased, there's sustained contraction, there's coupling of contraction, and you can see the baby who was just dealing with it is being caused additional stress. This is iatrogenic fetal compromise. Yes, the baby had a problem before. This is iatrogenic. It is lack of knowledge that is causing these problems. So cord compression, you can see now the fetus has to struggle. You can see this is what we call pencil tip variability. If you take a tip of a pencil and draw a straight line, that's what is called pencil tip variability. All these fetus needed was a bit of terbutaline, tocolysis. to increase the intercontraction interval, to abolish these contractions. So in chronic hypoxia, even if you are delivering in 60 minutes or so, please give tocolysis, make the uterus totally relaxed, take away those Braxtonese contraction. Because when you are in an acidotic state, every little bit of oxygen deprivation causes a problem. So let's improve the uteroplacental insufficiency as much as possible by taking away the contraction. But here, intravenous fluids, and then we know that because we didn't understand physiology, we were giving water to the mother, and some obstetricians also gave oxygen to the mother without realizing that when the mother's oxygen saturation is 98%, if you give additional oxygen to the mother who has normal oxygen saturation, it causes a hyperbaric oxygen situation, which causes vasospasm of the maternal arterioles. Placental blood supply reduces. Actually, the obstetrician or midwife who is thinking they are doing well to help the baby are making it worse for the baby. They also release oxygen-free radicals. So if you look at the Cochrane review in early 2000, the risk of acidosis in the umbilical cord, if you give maternal oxygen therapy for a woman who does not require oxygen, if she has sepsis, if she is having bronchial asthma, give oxygen because she needs it. Otherwise, her oxygen saturation is 98%. Fetal oxygen saturation will be 70%. Unless the maternal oxygen saturation drops below the fetal oxygen saturation, fetuses, they don't need oxygen from the mother. They have fetal hemoglobin. They have 180 to 220 grams. But here you can see it's only because of lack of understanding of what we do. We did crazy things. Guidelines recommended crazy things. And those of us who never thought beyond a guideline just simply followed. We're forgetting all what we learned in medical school or midwifery school, causing more harm to both the women and babies. If you give fluids, there have been cases of neonatal convulsions due to dilution and hyponatremia. But here, sadly for this case, this is what happened. Increased frequency, duration, strength, and basal tone. You can see what's going to happen to this fetus. You have a placenta. They are increasing the contractions, reduce the blood supply, and you're already, and the increased cord compression due to artificial rupture of membranes and release of prostaglandins and drainage of amniotic fluid, and you don't have normal placental villi. You have reduced placental villi. So they are struggling. You know, I always say, starting oxytocin and or prostaglandins, doing an artificial rupture of membranes or inducing them, is like you are going to a swimming pool to observe with coronary artery disease, but the pool attendant pushes you into the swimming pool and then puts a shark behind you to see how fast you can swim with the shark. Obviously, you're going to have decompensation and die. In the same way, we should not be surprised when some of these confidential inquiries are saying that babies are dying because we are doing crazy things. In chronic hypoxia and pre-existing compromise, we are increasing the stress instead of stopping the stress with terbutaline. Babies require intercontraction interval to be increased. They require these contractions to go away so that they can get oxygen, whatever minimum oxygen they can get from the placenta, they can get only if this myometrium is relaxed, only if the cord is open. So here there was progressive fetal hypoxia because they did the artificial rupture of membranes, and then that blocks, once the contraction starts or increases, it blocks the placental circulation, and therefore you're going to have reduced baseline variability, like pencil tip variability. And we know, those of us who understand physiology, what is the next organ to fail? The next organ to fail is the myocardium. Heart fails after the brain because you see the anatomy. The coronary artery comes from the root of the aorta, so it gets the best oxygen. The heart gets the best oxygen because from the root of the aorta, when the oxygen is maximum, it gets it. The next artery that comes from is the carotid artery from the arch of the aorta. So when there's hypoxic stress, initially the rest of the organs supplied by the main aorta fail, the liver, the kidney, so you have multi-organ involvement. Then the brain fails, hypoxic ischemic encephalopathy, you get reduced variability. And then the heart fails. When the heart fails, your myocardium cannot sustain its function. In the gym, when you get anaerobic metabolism in the calf muscle because you have been working without oxygen, you start slowing down and stop the exercise. You cannot carry on when there's lactate in your muscle. Heart is a muscle. So you can see a step ladder pattern to death, culminating in terminal bradycardia. If this baby has had no artificial rupture of membranes, had tocolysis without increasing the stress, myocardium would not have failed. But here, iatrogenic myocardial failure, then the biggest cat is called. Meow cat, cat 1, category 1 success. We want this baby out now and stress the poor anesthetist, stress the rest of the theater team, stress the neonatal team when they are doing something good in the neonatal unit, and then create a panicky situation from a very calmer situation before. And you can see when you allow this to carry on, when the baby has got already chronic hypoxia, when all the buffers are utilized, that baby is not going to survive. And imagine the trauma for the obstetrician and the midwife, due to lack of knowledge, the trauma they underwent. What about the family? The woman, the pair, the partner or the husband, the rest of the family. So you can see higher than expected baseline, reduced baseline variability, and shallow deceleration is not suspicious CTG, it is chronic hypoxia. And the management of chronic hypoxia is very, very simple. Let's explain to the woman that whatever damage that has already happened, we can't reverse it. What we can do is to avoid further damage due to a delay in delivery and ongoing Braxton Hicks on regular contraction. And whilst we plan our birth, let's avoid further stress with tocolysis. And this is not an acute problem, it's a chronic long-standing problem. And therefore, we don't have to rush in and deliver in 10 minutes, 15 minutes under general anesthetic. We can, once we give tocolysis, improve oxygenation, we can deliver within the next 60 minutes. So this checklist is there to identify these babies with previous placental failure or chronic hypoxia, and our management should be avoid further stress and deliver. So in chronic uteroplacental insufficiency, we have some babies with abnormal placentation, leading to development of abnormal villi. They are small, they can't do gas exchange. Some babies have villus in thrombosis or infarction, for example, preeclampsia. And some babies have perivillous fibrin deposition. You can get in diabetes, you can get in preeclampsia due to sluggish blood flow. So if you imagine that fibrin is getting deposited around the villi, which are supposed to be your alveoli, doing gas exchange, obviously you have problem oxygenating yourself. On top of that, if you allow these contractions to continue and cut off further blood supply coming from the uterine artery, you are going to be in trouble. So that brings us to another concept. We have just looked at chronic hypoxia. What about RUPI? RUPI is relative uteroplacental insufficiency. So under resting conditions, when the woman is coming to you in the antenatal period, if you put a CTG trace, it will be almost normal. You know why? Placenta normally has 40 to 50% reserve. So you need a large amount of placenta to die off before you see any Doppler changes in the ultrasound scan or CTG changes. So here, CTG will be normal. But the problem here is it is not a chronically diseased placenta. There is a problem of abnormal balance during stress. So normally when there is no stress, no contractions, the babies are fine. They are going to show a normal CTG because there's enough blood supply to the brain and the heart. So your baseline is going to be normal. Your variability is going to be normal. But if you have a fetus with increased metabolic demand, for example, a macrosomic fetus of a gestational diabetes mom, or chorioamnionitis, where the metabolic demand has gone up due to sepsis, there's more tissue extraction of oxygen, or if there's maternal pyrexia, the baby's metabolic demand increases secondary to increased temperature in the mom. In those cases, the babies require more oxygen, and this placenta may not be able to give it once contraction starts. And that's the time the babies are going to show you evidence of relative uteroplacental insufficiency. If you have a situation where the baby is normal, so the baby is not macrosomic, baby has no chorioamnionitis, but there is a reduced transfer of oxygen to meet the metabolic demands, for example, late onset placental failure. So the placenta is not totally messed up. So still there's some reserve, but very marginal reserve. But when the contraction starts, the babies don't have enough pools in their placental villi to oxygenate themselves. It's a contraction that makes it worse. Or there's maternal pyrexia, where the mama is utilizing more oxygen and giving less oxygen to the baby because her metabolic needs have gone up. Or if you have started oxytocin or prostaglandins in a fetus who is just in a fine balance without that 50% extra reserve, and now oxytocin reduces further oxygenation. In all these situations, you'll have RUPI. So usually it is late onset placental failure. And then you can see, as I said, approximately 40 to 50% of the placental function needs to be impaired to observe changes in the blood flow on ultrasound scan. And you can see CTG, as I said, will be normal at the beginning, and the moment the stress starts, the babies are either going to show you increase in the baseline heart rate, or you can see a sustained increase with the contraction, because when the contraction happens, there's not enough oxygen. There's not enough pools of oxygen to deal with it. So the baby has to increase the heart rate with catecholamines. And knowledge acquisition and transfer of knowledge with innovative team training, which is called CAT kits, just an opposite of Kit Kats. This is something that we need to be training our teams on to recognize evidence of RUPI on the CTG trace. You can see here, this baby, see those contractions. They are mild contractions. Normal babies wouldn't feel it, but if you are coming with RUPI, either your metabolic demands are high for that placenta, or the placenta is just in the marginal kind of reserves. With small contractions, you're going to have to increase your heart rate by pumping faster. That is RUPI, and this was a case of gestational diabetes mellitus. And we know from physiology knowledge that babies at term, when they move, somatic movements, their heart rate transiently increases, just like you and I in the gym. And when we stop the gym exercise, it comes back to normal. So in the same way, when they do somatic movement, there's transient increase in the heart rate. And we know on average for a human fetus at term, the amplitude is 15 beats and the duration is 15 seconds. Those are normal physiological accelerations. But if you are having these high amplitude accelerations, or often coinciding with contractions, they are not physiological. You cannot do that as a human fetus. And they are always compensatory responses and usually associated with RUPI. When there's relative uteroplacental insufficiency, your placenta is just be able to deal with your metabolic demand. You cause a contraction and cut off oxygen to the placenta. You sense that as a fetus. And immediately, your cord is not getting squeezed, so you're not going to show a deceleration. Your placenta doesn't have placental insufficiency like growth restriction, placental infarction thrombosis for you to show you a slow recovering deceleration. So, but you sense reduced blood supply and you started to overcompensate. And then you have these huge accelerations and larger amplitude, longer duration with contractions, obviously, and that is your relative uteroplacental insufficiency or RUPI. These are false accelerations. And when you get a fetus like this, ask yourself a question. in the antenatal period or in early labor or during induction, if this is what I'm seeing, knowing that as the labor progresses, contractions are going to get stronger, longer, and more frequent. Is this fetus fit to withstand the progress of labor? That's the question we need to ask. Again, you can see those contractions and look at those high amplitude accelerations. And those are coinciding often with contraction. And these are high amplitude, transient, and sustained increase in the fetal heart rate. What the fetus is trying to do is to, whenever there's a contraction, cutting off the oxygen. When the oxygen demand supply is not enough to meet the demand in that situation, the fetus releases catecholamines to perfuse the brain faster, increase the cardiac output, and also pump more blood from to the placenta to bring it back. So you get these huge compensatory responses with the contraction, and that is your relative uteroplacental insufficiency. So during labor, you may, when you induce a baby with RUPI, you could see this. You can see a sudden increase in the heart rate once you are given prostaglandins. Normal fetuses with good placental reserve, they don't need to do that. But if you are a fetus with poor placental reserve, you're not growth restricted. That is the problem. If you are growth restricted, you're managed to survive. In the late onset placental failure, you haven't reduced your growth, so your metabolic demands are high, and the placenta is not able to meet it, not when you are at rest, but when the contraction starts. And you can see here, it is very simple, because we learned that in rapidly evolving hypoxia, there's autonomic instability. We learned that in physiological CTG master classes. So once you have these contractions, if you have relative uteroplacental insufficiency, suddenly you don't get oxygen if you have induced them with prostaglandins. And therefore, what happens? You get zigzag pattern. That is your zigzag pattern. And again, you can see zigzag pattern. When the prostaglandins are administered, you get zigzag pattern. And these babies require immediate removal of prostaglandins and administration of tocolysis, because this is rapidly evolving hypoxia with autonomic instability. It's a brain problem. Zigzag pattern during induction of labor, think of RUPI. And the other pattern you can get is following a prolonged deceleration, a single prolonged deceleration. Normally, you will know, I'm sure you'll agree with me, that if you have a prolonged deceleration for 4 to 5 minutes, this fetus has fetal hemoglobin. They have large amount of hemoglobin, and they have a good placental reserve, and therefore they drop the heart rate for 3 to 5 minutes. I'm talking about in a reversible situation, not abruption, cord prolapse, uterine rupture. Those are irreversible causes. When there's a reversible cause, for example, uterine hypertonus, or positional change where the heart rate drops, you would expect them to drop the heart rate. And then when the stress goes away, to come back to normal baseline. I mean, that's the normal physiological response of a fetus who has got a large placental reserve, good hemoglobin, and fetal hemoglobin. But if you have RUPI, you can see here, you need to release catecholamines because your placental pools are smaller. Even 4 or 5 minutes is too much for you. So you need to pump back the accumulated carbon dioxide to prevent your respiratory acidosis at a faster rate. For example, if you dip underwater in the swimming pool, what do you do when you come up? That's what you do. You're trying to expel your carbon dioxide, which built up when you were underwater, and then you are trying to get fresh oxygen to oxygenate your myocardium and rest of the organs. But if you have lung disease and you do the same kind of dipping underwater for the same duration of time, you're going to do much more physiological changes because you don't have capacity, you don't have the reserves. In the same way, a fetus with previous RUPI will have to increase the baseline and sustain it for some time until the carbon dioxide accumulation goes away and the fresh oxygen comes back from the mother through the placenta. So uteroplacental insufficiency please think of these situations, anticipate this in cases of fetal macrosomia, or even if it is undiagnosed macrosomia, gestational diabetes, because in those situations, the placenta is not large enough. The placenta is maybe large structurally, but the villi, they have got terminal villus hypoplasia, infection, chorioamnionitis, and increased uterine activity. And on the CTG, please look for spurious or false large amplitude accelerations, the zigzag pattern, and sustained catecholamine release as we have seen. Finally, when we classify CTG as normal, suspicious, pathological, we know that it has been shown to have increased false positive rate, though earlier they thought 60%, but now with the current pH cutoff of 7.0 for umbilical artery metabolic acidosis, is over 95% false positive. In other words, 95% of operative interventions were potentially not necessary. We know that it increases inter- and intra-observer variability. It does not predict perinatal outcomes. It does not improve perinatal outcome if you look at the latest Cochrane review. Okay. So you can see here, we are having the patterns of injury in different types of hypoxia. Let's finish off this chronic hypoxia by looking at different patterns of injury in different types of hypoxia. So in chronic hypoxia, we know that almost the whole brain gets affected because this has been going on for 2-3 weeks in the antenatal period. Fetus has done all the compensatory mechanism. By the time you get reduced variability and shallow decelerations, that brain has got severe acidosis. So you get a global pattern of injury. In a gradually evolving hypoxia or subacute hypoxia, if you look at animal studies and observational human studies from medical legal cases, you would find that the peripheral white matter is affected. That's because this human fetus attempts to protect the central part of the brain stem, that's where the vital centers are, by diverting the blood from the periphery to the center. They do kind of redistribution. And because of the shunting of the blood towards the high central part of the brain, the territories of the brain far away from the vascular territories, they are the ones who get damaged, and you get watershed type of peripheral white matter injury. Whereas in acute hypoxia, because it is very sudden and there's no time for redistribution and protect your central parts of the brain, when there's a sudden drop of blood pressure in abruption, umbilical cord prolapse, uterine rupture, in those kind of situations, there's a sudden drop in the blood pressure. Perfusion is sudden and acute, and therefore the central parts of the brain, the basal ganglia that gets affected. And that's because if you see the anatomy, neuroanatomy, the most highly metabolically active area in a term fetus is this basal ganglia. And that's the part that gets affected. But when you classify CTG as normal, suspicious, pathological, it doesn't tell us anything. So when we started looking at physiological interpretation of CTG, and when we tried to look at types of intrapartum hypoxia, and then correlated with perinatal outcomes, we see, when I was working as a labor ward lead consultant at St. George's Hospital, with my team, I did this study. So we looked at 52,000 births, and our rate of hypoxic ischemic encephalopathy was 0.3 per thousand. We had only 16 cases. That's 1/5 the national average. But when we looked at the MRI scan of the brain, we were able to show acute hypoxia, just like in animal studies, and also observational human studies. When we do physiological interpretation of CTG, you can predict acute hypoxia cause injury to the basal ganglia and thalami, and subacute or gradually evolving hypoxia cause injury to the peripheral white matter. Well, you might say this is a single-center study and therefore we don't like it. Well, this is published quite recently in 2022. A group of obstetricians and neonatologists who were part of a large neonatal service in London. We looked at babies who had got brain injury, brain cooled, and we were able to show that in MRI scan of the findings in the brain, at the time of birth, if you see chronic hypoxia, 66% had total brain or global brain injury. Gradually evolving and subacute hypoxia, 100% had peripheral white matter injury, same as what we have shown in our study. And acute hypoxia, 100% had basal ganglia injury as expected. But the neonatologists were following these babies up for 2 years, 2.8 years to be precise. And you can see it's a chronic hypoxia that is associated with 40% of injuries, because these are pre-existing, long-term, and all the compensatory mechanisms are lost. Whereas a gradually evolving and acute hypoxia is about 16%. But the sad thing is, these are the babies, because they show very subtle changes, they are missed as suspicious CTG. And with acute hypoxia, the vast majority of them are due to reversible causes, but that's what panics obstetricians and midwives saying bradycardia. So, if you have this case where there's a primate gravida, 41 weeks, admitted with reduced fetal movements, and she is coming for induction of labor because of reduced fetal movements, and on artificial rupture of membranes, they found thick meconium. Our role is, as midwives and doctors, is to find out, based on the history of reduced fetal movements and meconium, what are the two possibilities? One is chronic hypoxia, the other one is chorioamnionitis. Because in chronic hypoxia, we know that intrauterine stress response, the fetal, and therefore the baby passes meconium due to stress. Or not only that, there's a renal shutdown. So if you have oligohydramnios, small amount of amniotic fluid, if you poo inside, if you pass meconium, it's going to be thick meconium because there's no dilution. Whereas in chorioamnionitis, we know that if you have infection getting in first, into the amniotic cavity, this fetus is going to have fetal breathing movements. And that's going to take the bacteria into the lungs. So the baby develops congenital pneumonia. And then when you have congenital pneumonia, there's going to be edema of the alveolar membrane. So once you are born and the umbilical cord is clamped, you're going to find it difficult to breathe because you have got pneumonia. And then you can see because of that, you can have postnatal hypoxia as well. On the other hand, if you have meconium with bile salts, bile acids, irritating the alveolar membrane and pulmonary vasculature, they undergo spasm, you can have primary pulmonary hypertension, which has a mortality of 20 to 40%. But if you look at fetal swallowing, the babies are not only breathing and practicing breathing with amniotic fluid, they're also swallowing amniotic fluid. So if you take bacteria in the amniotic fluid into your gut, you're going to have diarrhea, gastroenteritis diarrhea, and that's why you get meconium. So meconium is very closely associated with chorioamnionitis. So based on the fetal physiology, you would have said this baseline is not appropriate for gestation at 41 weeks. You look at the history, she has reduced fetal movements. She has got, meconium. And if you use the checklist, you would have done this. But here you can see they followed guidelines to the letter. They said reduce variability for 20 minutes, most likely sleep. That is nonsensical because none of us sleep at a higher baseline. We sleep at a lower baseline because you have to be under the influence of vagus to be quiet to fall into deep sleep. So even some of the basic knowledge is sadly missing in obstetric practice. So if you have reduced variability at a higher baseline, that baby is not sleeping. That's a problem. If you have reduced variability at a lower baseline, forget about this baby because that baby is sleeping because they're having deep sleep cycle. So they waited for 90 minutes and they also gave glucose. After learning in medical school, midwifery school, that glucose has facilitated transport. And therefore, unless the woman has hypoglycemia, baby is not without glucose. But these are all historical, cultural malpractices. So glucose, I'll go for a walk and come, and then let's do a CTG in 90 minutes because guidelines says reduced variability has to be persisting for 90 minutes. But you wouldn't have made that mistake because when you use a checklist, you know that this baby has pre-existing problem, chronic hypoxia, and we don't sleep at the higher baseline. And you would have said this fetus is not fit to undertake the journey of labor. And when we look at cycling during the physiological masterclass, we looked at cycling. Chronic hypoxia is one of the important causes of absence of cycling. And fetal infection, bacterial chorioamnionitis is also a cause. And we said, if your cause is reversible, if the cause is hypoxic reversible, you reverse and continue. But if it is a placental problem, disease placenta, which is not reversible, so it's not like stopping oxytocin, you have to intervene. In the same way, in non-hypoxic causes, you have to intervene. So the management is pretty similar. Whether you are diagnosing chronic hypoxia or chorioamnionitis, we know that continuation of uterine contraction causes additional stress. And this additional stress can cause rapid decompensation. So it's not only applicable to chorioamnionitis, but it is also applicable to other non-hypoxic causes, like fetal anemia and acidosis, where the continuation of contraction will make it worse. When there's thick meconium with oligohydramnios, when there's continuation of contraction and hypoxic stress might increase the risk of meconium aspiration syndrome and worsen the outcome. But here, unfortunately, they got the woman after 40 minutes and there's step ladder pattern to death. Is not surprising. So chronic hypoxia is very easy. A, B, C, D, your management. Avoid further hypoxic stress. Please do not perform artificial rupture of membranes. Do not induce this woman. Background history, the woman gives a lot of information. Let's explain to the woman that whatever damage that has happened, we cannot prevent it. What we can prevent is further damage. And that has to be explained to the neonatal team and the anesthetic team and deliver within 60 minutes with tocolysis. So this checklist is there for us to recognize babies, not only with chronic hypoxia, but also with pre-existing fetal compromise, because the question is, can this baby withstand further hypoxic stress? Is this fetus fit to undertake the journey of labor? Those of us who understand fetal physiology, this is the typical sinusoidal pattern. This checklist will pick this typical sinusoidal pattern, and the management is safe. Those of us who understand fetal physiology, we know is full sharp teeth pattern, and again, this will pick this up. So let me finish by saying, let's not use normal suspicious pathology. Let's understand fetal physiology. Giving water is good for if you are a fish. But fetuses are already in an amniotic fluid. That's water. Woman has 50% extra water as a part of physiological change in pregnancy. Why would we go and give water to treat hypoxia? Have we ever seen a nurse or doctor in a medical ward giving water to treat bronchial asthma or coronary artery disease? And water, not to the patient, to the patient's mother. Chorioamnionitis, that's sepsis. Have you ever seen a doctor or nurse in a pediatric ward or medical ward giving water to treat the sepsis of a child? And that water is not given to the child, but to the mother of the child. Fetal-maternal hemorrhage. In a case of postpartum hemorrhage, have you ever given water for the woman to drink? Not for the woman, but the woman's mother to drink or the partner to drink. So we need to go away from all these cultural malpractices, historical malpractices, and concentrate and prevent these babies with pre-existing damage from undergoing sustaining any damage. So if you can see this is the baby we want to have. The baby is able to react. Ugly deceleration, the better. And we don't need to do any cesarean sections on these babies who are showing a good stress response with a stable baseline and reassuring variability. Whereas the babies who come to us with pre-existing problem, they are the babies who need. So to conclude, there is onset of hypoxic stress for human fetuses, just like you and I. Then they compensate with the stress by showing decelerations, by increasing the heart rate with catecholamine response and redistribution. If you don't take any notice, they undergo decompensation. It's then when they have less oxygen going to the carotid artery and the cardiac output is not sufficient to meet the demands of the neurons, they go into neurological damage, multi-organ failure, or death. This is where we need to intervene by understanding physiology. If you go and do cesarean sections for pathological CTGs because there are ugly decelerations, we are going to increase the unnecessary cesarean sections without improving the outcome. If you leave it too late, calling it suspicious, because we don't understand fetal physiology, we are going to have a baby with neurological damage or death. And those babies who are coming with pre-existing fetal compromise, they have exhausted all their reserves, they have exhausted all their buffers and compensatory mechanisms in the antenatal period. And therefore, if you allow contraction to start, their onset of damage and decompensation is much, much sooner. And that's why we need to understand chronic hypoxia better. So intrapartum fetal monitoring, let's get chronic hypoxia right in order to make sure that these babies are not having pre-existing damage, babies with pre-existing damage, they are picked up well so that we don't have to push them into labor and cause